Good day, good evening. I'm going to present a talk on the update on gene therapy for hemophilia. My name is Glenn Pierce. I'm the Vice President of Medical for the World Federation of Hemophilia. My disclosures are included here. I work with a number of different companies, both in the hemophilia gene therapy space and outside of the hemophilia gene therapy space. My agenda: status of the phase 3 gene therapy trials for hemophilia B and A, the knowns and the unknowns for AAV delivery, looking at the benefit-risk ratio in perspective for both of those diseases, B and A, and then future initiatives in research that can cure hemophilia. The basics of hemophilia: deficiency of factor VIII, the majority of patients, and deficiency of factor IX, a minority of patients. The prevalence for both of these diseases is about 3 in 10,000 males at birth. And in high-income countries, 100% have been identified, but that's 15% of the world. Lower income nations, as few as 8% have been identified, and that is the vast majority of the world. We have wide disparities as a result in management and in access to treatment, especially within the 70% of the world. What's the human phase? Well, the 15% are doing well with state-of-the-art therapies, including prophylaxis to prevent bleeding episodes, while the 70% have struggles to obtain any treatment at all, and in many cases do not obtain treatment, have a high mortality, high morbidity, with crippling and death frequently in childhood. We have a humanitarian aid program at the World Federation of Hemophilia, and we have just published the 5-year results, if you're interested, in Lancet Hematology last month. So what about gene therapy? Well, the concept of gene therapy is pretty simple, and it really does represent the means toward the end for a cure for hemophilia. It's simple: deliver a replacement clotting factor gene and restore hemostasis. But there have been many failures along the way. Initial study with retroviruses didn't work. Study using ex vivo electroporation of autologous fibroblasts, reimplantation into the peritoneal cavity, also did not work. One patient received adenovirus, had a toxic reaction, didn't work. And then AAV, adeno-associated virus to the muscle, didn't produce sufficient levels of factor IX, and AAV to the liver initially was abrogated by a cytotoxic T-cell response that destroyed all of the hepatocytes containing the factor IX gene. And in the entire field, there have been 2 successes to date: one for Leber's congenital amaurosis, congenital blindness, and another for spinal muscular atrophy, a lethal disease in children. So what about hemophilia? Well, we have a number of hemophilia trials that are ongoing, phase 1-2, as well as phase 3. And I'm going to concentrate on the 2 that have actually released phase 3 data: Valoctocogene roxaparvovec from BioMarin and etranacogene dezaparvovec from CSL Behring and Unicure for factor VIII and factor IX, respectively. The other trials are in various stages. And I will only point out the Pfizer trials, which are in phase 3 for hemophilia B, but no results have been reported over these last 3 years or so. And the phase 3 trial for factor VIII had very high elevations in factor VIII itself. Patients were started on DOACs, direct oral anticoagulants, and this trial was put on hold, is now resumed with appropriate safeguards in place. So for valoctocogene roxaparvovec, we've had 3 publications, 2 on the phase 1-2 study, and then 1 by Ozella and colleagues on the phase 3 study. The phase 3 study and the phase 1-2 studies transfer of B domain deleted factor VIII gene to people with severe hemophilia A, enabling endogenous production from the hepatocytes, which is a heterologous cell that doesn't normally produce factor VIII. Studies are open label, single arm, The dose for the phase 3 is the same as the high dose in the phase 1/2 study, 6E13 vector genomes per kilogram. And all of the participants are adults with severe factor VIII deficiency, a history of factor VIII infusions, and no history of antibodies or anti-AAV5 antibodies. So either inhibitor antibodies or AAV5 antibodies. And results from the 2-year analysis have been presented that are shown here. This is showing all of the patients over 2 years, and then a cohort of about 17 patients during the 3rd year. What we can see is a characteristic early rise, looking at the means, that peaks around 26 weeks and then gradually comes down by 1 year. At 2 years, it continues to trend downward, and at 3 years, it continues to trend downward as well. Medians are much lower than the means, so the means are influenced by some patients who have some very high levels initially. And there is, as you can see, a gradual loss of factor VIII activity, so a question of durability. Variability is high as well, as is the reliability, which I'll discuss in a moment. Does it work? Yes, it does work. This is looking at patients' treatments prior to receiving gene therapy compared to a year after receiving gene therapy. And one can see that the annualized use of factor VIII drops dramatically. The number of factor VIII infusions from about 130 drops substantially. And the number of treated bleeding episodes goes from a mean of about 5 down to a mean of about 1. And so there isn't any question but that it's providing sufficient factor VIII to protect against most bleeding. Well, what about safety? Well, in this study, ALT elevations occurred in 89% of patients. Corticosteroid-related AEs as a result of treatment of the ALT elevations occurred in 60% of all of the patients. ALT elevation occurred in 8 above 3 or above, occurred in 8% of the patients. And in one of those, it was a week 70 in the 2nd year that he had a grade 3 ALT elevations. No thromboembolic events, no evidence of any neutralizing antibodies to factor VIII. This is the phase 1 data. These are the phase 1 data. And what we can see if we look at the orange bars, this is the 6E13 dose, and this is the same dose that the phase 3 patients received. So you can once again see the early rise over the first half year, and then a gradual drop over a period of 5 years. So we've had a drop of about 50% at the end of year 2, and by the end of year 4, another 50% and nearly 50% at the end of year 5 at this dose. What's important, though, is that the same dose was used in phase 3, but instead of at the end of the first year, a 60% or 60 IU per deciliter value for factor VIII as a median, these patients had a median less than half that. And so the doses are not fully comparable between the studies, even though they're both 6E13 doses. And it does suggest that the patients will continue to drop from here and have lower and lower factor VIII levels over a period of time, as I showed you from the 3-year data on the previous slide. So the conclusion from the phase 3 study is that in patients with severe hemophilia A, the lactocogene roxaparvovec provides endogenous production of factor VIII, significantly reduces bleeding and factor VIII use. But the unanswered questions from this study include the role of corticosteroids and other immunosuppressives, such as tacrolimus and MMF, for a median of 8 months in the vast majority of patients. The causes of elevated ALTs, are they due to the cytotoxic T cell responses that Mano et al. Showed back in 2006 from the factor IX AAV studies? Or are they due to an inflammatory response toward capsid that's destroying the cell? or an unfolded protein response, because factor VIII is a challenging protein for the cell to make, versus an innate immune response to nucleic acid species, such as double-stranded RNA or CPGs that may be in the vector or in the ITRs of the construct. Unknown answers to these questions that account for the loss of the durability. One patient was found to have a transcriptional silencing. And so there are other parameters at work here at the molecular level that may be responsible as well. 14% of the patients got very low responses, unclear why. It wasn't a question of having neutralizing antibodies to the AAV. So no known reason. And then eventually, many of these patients are going to intersect the x-axis and have and no longer have factor VIII expression. That's moving in that direction for the phase 1/2, and you can see for the 3-year data for the phase 3, it's also moving in that direction. So let's talk about etranacogene dezaparvovec, which is the AAV for factor IX. And that's quite a contrast with what I've just presented for factor VIII. What we can see here from data that have been presented at multiple meetings is that we have stable factor IX expression of about 37-38% over a period of 18 months. And so we don't have the decline seen with the factor VIII study. The vast majority of these patients were able to go off prophylactic therapy. The 2 patients that could not, one had a very high AAV5 neutralizing antibody titer, and the other had an infusion reaction and only received about 10% of the dose. A fewer number of these patients, 16-17%, had elevations in ALT and were treated with steroids for an average of about 2.5 months, as opposed to the 8 months seen in the factor VIII study. So quite different in terms of the adverse events from steroids as well. So how do we think about the benefit risk of gene therapy when we put it all together? Well, it's really efficacy balanced against safety. And it's once and done, a curative therapy for which there would be huge benefit versus a therapy that will only last for 5 to 10 years and will preclude the patient from taking any other AAV-based therapy for the foreseeable future. We also have protein therapeutics, extended half-life products for both A and B, as well as emicizumab for hemophilia A, that need to be balanced out against the benefit risk of gene therapy as well. So we're left with a series of knowns and unknowns, and that's a useful framework that I'll discuss on the next slide. It also allows us to use this framework to look at shared decision-making between the patients, their healthcare providers, and amassing the information required to make this kind of a decision, which is an irreversible decision for the patient. And it goes without saying that the benefit and risk is also a function of where one lives. Are you in the 15% that has state-of-the-art therapy, or are you among the 70% that has inadequate or no therapy for the treatment of hemophilia? Big differences there. Looking more specifically at the knowns and the unknowns, what we know, examples there include steroid toxicities, the transaminase elevations, and the peri-injection reactions that are generally well controlled. What we know we don't know. Well, what is the significance of liver enzymes in the first year? And maybe more importantly, what's the significance of liver enzyme elevations beyond the first year? What's going on with regard to the patient? And what's the significance of integration? Integration is also something that we forgot we know. We've known AAV integrates for 50 years, but it's only recently that we've begun to seriously look at what the effect of integration might be, both in animal species as well as in humans. And the other question that we forgot we knew was acute liver failure. We know viruses can cause acute liver failure. AAV2 has been implicated in acute liver failure in a couple of hundred patients in the UK earlier this year. But we have forgotten that administering viral vectors, AAV is an example, in very large quantities, quadrillions of vector genomes, can also cause acute liver failure and has in diseases outside of hemophilia. And then the most concerning is what we don't know we don't know. We never expected thrombotic microangiopathy from AAV therapy, complement activation, a dorsal root ganglion, sensory neuropathies. And what's next? We don't know because this isn't new technology and we need to be prepared for the unexpected. Well, how do we get prepared for that? We have major challenges in identifying safety signals in rare disease populations. And initially, gene therapy will be rare, few, but it will be scattered also around the world. If we don't accumulate all of the data in a single global registry, patterns of rare safety events are going to be difficult or delayed in identification. And over time, we do need to understand long-term safety, durability, and variability of the gene therapies that will be used in hemophilia. And it goes without saying that patient safety is all of our responsibility. This is something I feel very strongly about, that we do need, based upon our history in hemophilia and the viral infections that have occurred within our population that have destroyed a couple of generations of people. We do need to be aware of safety and we do need to take responsibility for it. So at the World Federation of Hemophilia, over the past few years, we have developed the Gene Therapy Registry, published as an SSC communication by the ISTH in the JTH 2020. Primary objective is to determine the long-term safety of factor VIII and factor IX gene therapies in patients with hemophilia. Secondary objectives include looking at efficacy and durability, as well as to look at quality of life, long-term quality of life, post-infusion. We have a number of partners that we've had discussions with. The first four will be working with their national registries, United States, Germany, France, the Netherlands, and then a number of other countries as gene therapy gets introduced in those countries. We're also interested in the Gulf states, since you do follow FDA or EMA guidance, and it will be important to include your patients in this registry as well. What's the value of the registry? Well, it provides a framework for standardizing all of the data collection globally. Same questions, same responses globally. It's for looking at long-term safety monitoring to identify any early signals, facilitating research to understand the implications of gene therapy, collecting patient-reported quality of life data, and informing for advocacy with governments to be able to get reimbursement for the gene therapy. So where are we at? Well, in the intermediate future, gene therapy will revolutionize medical care in the form of cures, not necessarily treatments. And the timeframes, though, for hemophilia B and hemophilia A are quite different. Hemophilia B looks like it lasts for a long period of time and may, in effect, be providing for or will provide for a functional cure for a long period of time. That's not the case yet for hemophilia A. I would remind us all that in all of the hundreds of gene therapy AAV studies that have been done, 2 products have been approved. And so this rush to the clinic by companies, by academics, and to the market has meant skipping the understanding of the biology of these vectors and our host response to receiving quadrillions of vector genomes over a period of 2 hours. Some of my friends and I have written about this kind of thinking and calling for more research to understand many of the questions that I have raised in this talk. As we have progressed with AAV gene therapy, we've continued to increase the doses in order to get efficacy. And so doses of 1E14 vector genomes per kilogram and above are toxic and have caused death in children with different monogenic diseases. I would point out that the BioMarin study is at 60% of 1E14, and the uniQure CSL hemophilia B work is at 30% of 1E14. So we're not that far away from vector doses that have caused very severe and life-threatening toxicities, something to be aware of. An example is cancer. And so there have been 4 cancers in various hemophilia studies. None of these have been found to be associated with the AAV therapy. No evidence of vector genomes or pieces of the vector genome within the tumor itself. But they point out to the need for vigilance and surveillance to look, because we have integration. And while integration is rare, when one is administering quadrillions of vector genomes to a patient, vector integration occurs in tens of millions of hepatocytes within the liver. So a rare event in a very large dose is not such a rare event and is something to be aware of. What about all the toxicities that have been associated? This was all gone over at an FDA safety summit about a year ago. I've discussed the hepatotoxicity. I've mentioned TMA, seen primarily with AAV9, the neuropathies, the sensory neuropathies that have been seen with AAV9 and 10 in non-human primates, as well as histologically in humans, and perhaps in one ALS patient as well. And then neurotoxicities from intraparenchymal infusion of the AAV. That cause lesions within the brain as well. And so these are all toxicities to be aware of. So what can we do? Well, we have a couple of choices. Continue to pursue AAV. We've started with lethal diseases such as SMA. We've moved to serious diseases that have no treatment, such as Leber's congenital amaurosis. And now we're moving into non-lethal diseases that do have very good treatments, such as hemophilia. And so one has to continually assess the benefit risk in each of those situations. And it is quite different among these 3 different types of diseases. What can we do to improve AAV? Well, a lot of work has gone into improving tissue tropism and concomitantly transduction efficiencies. We're administering quadrillions of vector genomes. A very, very tiny fraction of that forms stable episomes within the hepatocytes and produces factor 8 or factor 9. Any improvements that can be made in increasing the efficiency, small amounts, can have a dramatic effect on being able to decrease the dose of the AAV. Important areas that are undergoing widespread screening, looking for improved AAV vectors. Looking at pre and post-dosing immunity, we're doing very little in that regard. Being able to treat patients who are AAV seropositive, we don't have anything viable at this point. And then dealing with the post-dosing immunity, which is very high, antibody levels as well as a cytotoxic T cell response, is also something that we have not figured out how to deal with. Manufacturing improvements are continuing along the way as we make our way to the clinic. Gene editing is going to be required for small pediatric patients. There's no question about that. And we are making headway in moving forward with clinical trials, development of clinical trials in hemophilia for gene editing, for factor 9. Factor 8 is a different story and is not ready for prime time. That will, of course, have an influence if we can permanently integrate the factor 9 gene into the albumin locus on duration and should provide lifelong duration. Regulatable promoters have been something that people have been looking at for decades without significant progress. The other alternative is to leave AAV. But other viral vectors, really, although people have suggested them, are going to have the same problems. We're dealing with a host response to a viral insult, viral infection. And we've had 500 million years as vertebrates to be able to counter the virus. Viruses have 500 million years in vertebrates to be able to infect us. And so another viral vector is not necessarily the solution. Non-viral delivery could be the solution, and as you all know, it's terrific for mRNA and getting mRNA into the cytoplasm, but it's not so good for getting DNA into the nucleus, and that's the problem. A virus can get DNA into the nucleus. Non-viral systems are very, very inefficient at doing that. And then cell therapies, simply to deliver the factor VIII gene via autologous cells or allogeneic cells, are just not ready for prime time. And so that's not viable at this point. So we're really left with AAV or improvements in non-viral delivery. With that, I'll stop and appreciate your attention.